Necessity is the mother of invention. Situations demand solutions. So is with surgery in lung cancer following radiotherapy and chemotherapy. It has evolved over the years, starting commencing with the complications of radiotherapy and chemotherapy, which presented as hemoptysis, lung abscess, empyema, BPF, which necessitated surgery. It then further went in cases of superior sulcus tumors with nodal involvement and severe brachial plexus pain, where radiation was offered, and then surgery. And in patients who had early stage non small cell lung cancer who declined surgery for their own personal reasons, took up stereotactic body radiotherapy. And these patients usually did well. However, a few of them developed recurrence or there was persistence of disease which necessitated and surgery. Then came the scenario of downstaging of malignancy, stage 3A, stage 3B, traditionally non-operable. Chemotherapy and radiation was done, and they found that they could downstage the tumor and then take up for surgery. And finally, this new and evolving concept of salvage surgery when no therapeutic option is available. This is a classical case of early stage NSCLC after stereotactic radiotherapy who previously declined surgery. The CT clearly shows a solitary lesion. He was 81 years of age, refused surgery, and was treated with radiotherapy. However, the same patient, 18 months later, showed progressive disease. Salvage pyelopectomy was necessary to obtain a complete resection. Superior sulcus tumors, as mentioned earlier, N2 involvement, had or were given induction chemoradiation and then followed by systemic cisplatin based chemotherapy. And after a gap of 4 to 8 weeks, surgery was performed. Now, the issue in stage 3 is lymph node involvement. It could be bulky, it could be discrete, and this constitutes stage 3A for T1 to 3 patients with ipsilateral mediastinal disease. The overall 5-year survival rate is a dismal 10%. Now, N2 disease is schematized as occult nodal disease, discrete nodal disease, and infiltrative nodal disease. The first two categories are happily amenable to surgery. The latter, where there's infiltration, is not because complete nodal clearance cannot be achieved. This article shows that most recent prospective trials are in the adjuvant setting have been able to show clear benefit. However, in neoadjuvant chemotherapy, a question or a shadow was cast. Despite this, certain patients were treated with neoadjuvant chemotherapy because it provides prognostic information, can downstage a patient, and improve resectability. Usually, 3 to 4 cycles are given before surgery for neoadjuvant chemotherapy. Although the current consensus recommends the use of postoperative chemotherapy, both strategies need to be explored. This is elaborated by Burdett in 2014, where he indicated that preoperative chemotherapy improves overall survival rate and recurrence-free survival for operable NSCLC compared with surgery alone. Comparing the benefits of chemoradiotherapy and chemotherapy for resectable stage 3A2 N2 small cell carcinoma, this meta analysis which analyzed 1,433 articles, 18 studies, and three randomized controls, included 334 patients, where 157 underwent induction chemotherapy and 177 underwent induction chemo radiotherapy. So we had one arm with chemotherapy and another arm with chemoradiotherapy. That is of significance, especially when it comes to surgery. And this clearly showed a 5 year survival rate benefit of 35.8%. Our patients who were not downstage did not get any benefit. Now, what's the theoretical rationale behind preoperative chemotherapy? 3 to 4 cycles, as we mentioned. This offers cancer shrinkage of primary site and lymph node by pre-op chemotherapy and may make surgical resection earlier. Now, again, with pre-op CT chemotherapy combined with radiotherapy might make possible the complete resection of locally advanced cancer, that is downstaging of stage 3A and 2 and 3B disease. Pre-op CT may also prevent the spread of cancer cells during the surgery. These are the three primary reasons and the rationale. And of course, who undergo pre-op chemotherapy have more chance of a safe outcome from systemic CT compared with patients who have already undergone surgery. So those who have received and tolerated chemotherapy prior to surgery, they have a better chance of it being tolerated post-operatively. And of course, responsiveness to chemotherapy may be evaluated before surgery. In clinical settings where surgery is difficult to come by, it may be quicker to arrange chemotherapy than to arrange surgery. So it could wait. While waiting for surgery, chemotherapy could be offered. Now, what's the case against preoperative chemotherapy? Only immediate surgery without preoperative chemotherapy can provide precise pathological staging because tumor shrinkage by preoperative chemotherapy may result in underestimating the disease stage. Further, patients who undergo immediate surgery with postoperative chemotherapy have more chance to undergo surgery safely as compared with a patient who has been enfeebled because of chemotherapy preoperatively. If chemotherapy is ineffective or only minimally effective preoperatively, the delay in surgery can lead to disease spreading. Although this only constitutes a minor or small percentage of patients, but definitely this risk exists. Now comes to salvage surgery. This is a relatively new entity in thoracic surgery and oncology. This refers to surgery as only remaining therapeutic option in patients who were treated with high dose radiotherapy, stereotactic body radiotherapy, or chemoradiation for early stage lung cancer or for locally advanced lung cancer. So, all this chemoradiation provided, given that patient does not have any improvement, this is the only remaining therapeutic option, that is salvage surgery. This paper, which reviewed 48 salvage resections, and the author concluded that salvage surgery may be considered a worthwhile treatment option with low mortality, acceptable morbidity, and relatively good survival. Now, what are the indications for salvage surgery? Broadly, early stage NSCLC after radiotherapy, where local disease persists or local recurrence occurs, and of course, complications of radiotherapy, lung abscess, BPF, hemoptysis. So that's early stage NSCLC, and then local regionally advanced NSCLC after full dose chemoradiation. Again, in those conditions, the local regional disease is persisting or there is recurrence. And of course, its inherent complications will warrant salvage surgery. This is a classical example of tumor following necrosis following radiotherapy. The lesion here is clearly defined yellowish necrotic area and as compared to the normal lung which is above, well appreciated as opposed to the necrotic tissue following radiotherapy. Another case where a large abscess cavity colonized by bacteria and fungi in a patient who underwent full dose chemoradiation 6 months earlier for right upper lobe adenocarcinoma with mediastinal involvement. Well, we were left with no choice but to do an intrapericardial pneumonectomy. And the pleural cavity required irrigation with a tube at the apex and two other tubes at the base. Yes, BPF, bronchopleural fistula, the curse of tumor necrosis following radiotherapy is clearly seen in this patient here. The hole is well visualized. And when we instill saline into the pleural cavity and ventilate the lung, we can confirm that that hole is where the leak is. This requires resection of the localized tumor. So salvage procedures after full chemo full radiation, in contrast to surgery or salvage surgery after chemotherapy, is technically very demanding. Because of radiation, it's a lot of inflammation and fibrosis occurs. The dissection of the pulmonary artery and the mediastinal lymph nodes becomes a challenge and can cause damage and bleeding. Due to the more central irradiation and intrapericardial dissection is often required, as opposed to in a peripheral lesion where radiation is being given centrally and intrapericardial dissection can be avoided. And to prevent a BPF, protection of the bronchial stump with well vascular flaps is recommended. Omental flaps, intercostal pedicles, or pericardial fat. Sujimoto et al. Clearly demonstrated that VATS is possible in peripheral stage disease because adhesions were limited and easily divided, central structures were intact, probably because of peripheral and not central irradiation. So, points to ponder a new field, radiation, chemotherapy given in patients, and then followed up with surgery. Hence, early stage NSCSC after SRT who earlier declined surgery will benefit, especially in persisting local disease, local recurrence, progressive disease, complications of chemotherapy or radiation to the lung, hemoptysis, lung abscess, empyema, bronchopleural fistula can all be fixed, that again requiring surgery. And happily enough, downstaging occurs in especially superior sulcus tumors, T13, N2M0, and in much fewer cases, T4N0, 1M0, and then follow it with surgery. And finally, this new kid on the block, salvage surgery after chemotherapy, is definitely a superior option over full dose chemo radiation for locally advanced disease for reasons stated before. And salvage resection after SRT for peripheral tumors is definitely a feasible state and must be considered. Finally, the 3 year survival rate increases fourfold in patients who have surgery following radiotherapy and chemotherapy, an increase from 10 to 38%, which is extremely gives hope and happiness to the patients.